Hello, and a warm welcome to everyone joining us from around the globe. We are excited to have you with us for this AI Corespot webinar, where will uncover technology's vital role in various industries. I hope you all are having a wonderful day. I'm Archana Nair from AI Corespot, and I'll be your host for today's session. Today, we'll have yet another healthcare-related conversation infused with technology that is transforming healthcare through cutting-edge technology. Joining me today are Nitin Naveen, VP of Innovation and Strategy at AI Corespot, and my colleagues Arvind Kannan and Naveen. Special thanks to them as they will help us make this event smooth and glitch-free. On the screen, joining us are esteemed guest speakers and our moderator. Let me give you a quick intro to AI Corespot before we dive into today's discussion. At AI CoreSpot, we have been working to build an exceptional professional community that is centered around the latest technological developments from for over 3 years. We have been gaining headway by introducing a new subject every month and providing an in-depth analysis of every technology-related industry. We prioritize industry-backed webinars, face-to-face and hybrid events, ensuring our knowledge base is built on credible data provided by esteemed industry speakers, study subject matter experts, and our trusted partners. To shed light on ever-evolving market, we enhance our digital material with blogs, podcasts, videos, news, and newsletters. We are excited to share all that we learn about cutting-edge technology as we explore them in the upcoming months. So stay tuned with our daily news and upcoming webinars by following us on social media. Today's talk is all about transforming healthcare through cutting edge technology. Our expert panel will unpack how AI is changing healthcare, making admin tasks easier, improving diagnostic accuracy, enabling ongoing patient monitoring, and tackling key ethical and regulatory challenges. And if you have any questions, please drop them in the question and answer section. That is a Q&A section, and I'm sure our moderator will pick them up as time permits. Now let us meet our speakers for this session. We have Linnea Talbot, Senior Director at Vizient Incorporation, David Finkelstein, Chief Information Officer, River Spring Living, Sharad Babu Krishnamurthy, Director of Genomic Health and Informatics, Columbia University Irving Medical Center, and Mark Johnson, VP Global Healthcare and Life Sciences, Innovation and Strategy from Infovision. Special thanks to Mark for moderating this discussion. Here's an important disclaimer. The views shared by the speakers are their personal ones. They are not related to any organization that they represent. Now, I know you all are eager to get started, so not taking any more time of yours, let me hand over the stage to Mark Johnson. Over to you, Mark.
Thank you very much for that introduction. Good morning to everyone. I'm Mark Johnston. I'm the head of Global Healthcare Innovation at Infovision, where I lead an transformation group across healthcare and life sciences. Infovision is a global digital transformation innovator with a dynamic team of about 3,000 team members spread across the globe. And we work to shape the future of healthcare and improve lives. And we offer everything from technical staff augmentation through digital engineering and the practical use of emerging technologies to improve lives. So today on the webinar, Transforming Healthcare Through Cutting Edge Technology, we're at a pivotal moment in healthcare where emerging technologies are revolutionizing both patient and operational efficiency. So today's discussion will explore how innovations, we couldn't get away from a webinar today without bringing up the word artificial intelligence. Have to do it. It's top of mind. It's the buzz for the last 24 months, but it's the key. It's the key point. It's going to continue to innovate. So we will be focusing on it today. Genomics, digital health platforms that are reshaping healthcare delivery while addressing critical considerations around implementation, risk management, and patient outcomes, obviously. So I'm pleased to welcome our distinguished panel of healthcare technology leaders. And now I'd like to invite each of our panel to introduce themselves and give us a little bit of their background and what drew them into healthcare. And with that, if David, if you'd like to start, we can start with you, David. And if you could give us a little bit of background. Thank you, sir.
Thank you. Name is David Finkelstein. I'm the Chief Information Officer at River Spring Living. We are a not-for-profit, long-term, post-acute care provider based in the Bronx, New York. We serve about 18,000 New Yorkers every single day in our skilled nursing, assisted living, independent living, home care, and managed care programs across the 5 boroughs. And healthcare and healthcare IT has been a passion of mine for the last 30 some odd years of my career, in figuring out how to give the patients and residents and members that we serve the best possible lives and outcomes. And AI has been a game changer in recent years, and looking forward to discussing that in this conference.
Thank you very much, David. And Linnea, over to
Hi,
you.
good morning. Yes, Linnea Tobier, Senior Director for Vizient. So I'm a registered nurse by trade, background in surgical services, operating rooms, sterile processing. And now I work at Vizient, healthcare improvement company, supporting our members from some of the top healthcare organizations with process improvement and just increasing their care for patients. I specifically lead our Chief Nurse Executive Network, working with our C-suite leaders to get them together for education and networking purposes. So what really drew me into technology is I think it's going to be the future of the healthcare. You know, if you are not a part of it, be prepared to be left behind. So I think it's almost imperative that healthcare providers understand AI a little bit more.
I appreciate that. Appreciate your background. I think we're all interested in moving at the end goal. And I learned this several years ago back that, you know, at the end of the day, it's all about the patient that drives everything across all the verticals, all the areas that we all operate and work in. But if we're not improving what we're doing to improve the patient outcomes, reduction in cost, more efficient delivery, I mean, that's the goal. I want to think that 99.9% of everybody involved in healthcare, we're all working towards that goal in a very complex system. With that, Krishna, can you give us some background on the very interesting background and bringing a genomics perspective into today's call, which is going to be a key dynamic, already is, but I think more and more as we move forward to getting to the front end of being able to predict disease and provide treatment plans prior to kind of where we sit today. We have some of that, but today where we sit and you know, we're diagnosed and we have to formulate a treatment plan, we can get ahead of the curve and prevent some of this from happening. So if you give us an introduction and some of your background and how you got drawn into healthcare.
Thank you, Mark. Hi, everyone. I'm Sarat Babu. I'm the Director of Genomic Health and Informatics at the Center for Precision Medicine and Genomics at Columbia University. So the mission for the center is to bring precision medicine closer to clinical care. And that's what actually drew me into this field, and giving back to the community is what makes me want to work in the healthcare industry. And like my background is in bioinformatics, so I'm a bioinformatics data scientist by nature, and I've been working in this field for 10, 12 years now. And yeah, so digging through the genomic data and bringing out the full potential of it, like be it prevention, screening that Mark mentioned, or like identifying the prognosis or the treatment plans that is specialized for every patient, is the goal of precision medicine, and that's what I'm more interested in talking about today.
I appreciate that. It's going to be a very interesting topic to address today, and I'm going to stay with you, and then we can open up to the panel as well. And we're going to dive into that word that everybody is top of mind and tired of hearing about, but it's going to revolutionize healthcare. I think it's the most transformative innovation, probably surpassing both the internet and maybe the personal computer, some would argue, and that's artificial intelligence and large language models. So to the panel, and Sarath, we can start with you. How can AI and LLM solutions contribute to improving patient care and service delivery? If you can, you know, provide some thought process there. I know you're not on the delivery side specifically, but if you want to start us out there, and then we can move across the panel, because I think it affects everybody.
Okay. Yeah, so like AI is everywhere, and obviously this in the genomics field as well. And then in terms of machine learning and AI, it has been inherently in there all along, even before it became a buzzword recently. right? In terms of genomics, there is a lot of data that is there, and over the years, the technology has evolved more in terms of sequencing, and the amount of data that is coming out every day is increasing exponentially. And for that, if we have to make any meaningful get any meaningful information out of it, it is important that we get the like AI technologies involved in it. And so some of the areas in terms of like the healthcare and clinical care aspects, I think AI has made a significant impact in terms of imaging analysis. So I can bring some of the examples that we use at Columbia are like a professor who is working on the breast cancer identification, looking at the pathological images, like on the biopsy images, and looking at the MRI and slicing and dicing those images to identify who could be who could be screened for breast cancer much earlier than any other technologies that are out there currently predicts them, right? How better can we diagnose? And then one of the areas is identifying what gene and what mutation do they have, and how can we give a specific treatment for those patients who are identified with those specific genes. And one of the things that we do with EHR data is to actually identify and which patient has what kind of phenotype do they have, right? In terms of when it comes to research, it's doing the phenotypic, applying the phenotypic algorithm. It gets much easier when we have the metrics. Okay, this is the top level filter that we're doing, and then how we are segregating each patient into groups. But it's only working only if we have the number of features that we are looking at is less than 10 or so. But when we go into a lot more features involved, especially in the imaging data, it gets a lot more complex. And that's where AI actually helps in identifying, in segregating the patients into different phenotypes. So this, on top of any additional data that we have, be it the genetic data or their clinical record with what kind of symptoms they have, combining all these three actually takes it to the next level in terms of diagnosing the patients and treating them as well. And obviously, like, there is a large another area which is drug development, where AI has actually impacted a lot more. Like one stat that is still staggering to me is that 90% of the drugs that go that is being tested actually gets failed, right? It's only 10% that make it to the market. So there is a huge scope for AI in that field, and that is where it is actually currently helping in terms of target identification and which gene to target, and modeling the design, modeling the protein is also where AI is actually helping out. So
I appreciate that. I think the panel's diverse enough. What's interesting about the panel today, I think if everybody can pick up on, and looking at backgrounds here that we discussed, is we have everything from pre-symptomatic identification, pre-symptomatic of diseases, which is going to be key because everything downstream in the delivery section of healthcare is kind of responding to an issue that's already at hand. So there's limited treatments and plans to address the disease itself once it's manifested in a diagnostic situation. So it's very key that here today we have way upstream the work that's going on, that Srath is doing, very important work on the genomics side to identify those at risk and to intervene very early on. So all these, and then we have the delivery side represented here today, which is also obviously a key to the whole paradigm. So with that, David, and your background and your history, like I think everybody on the panel, AI's been around for a while. It's not just been now that it's the top of the hype cycle in the last 24 months, but it's actually been around for several years, if not a decade or more longer. So, David, I want to get your perspective on where you see it, if you're utilizing it today, and if not, where you see the perspective on where AI and LLM solutions are going to improve the delivery of care from your perspective.
So I think the best way to start the conversation is discussing one of the success stories that we've had with introducing AI-powered sensors into the care delivery of our facility patients. We are a long-term care facility. One of the larger areas of our organization is a skilled nursing facility. Many times residents come in after having surgery at the hospital, whether it's a knee or a hip replacement and they need some rehab, or it's a traumatic injury and they're just recovering and can't go home yet. And one of the areas that we've noticed as an issue is falls within the facility. People come into our organization, they're disoriented, they're on pain medications or other medications that make them basically not really fully aware of their surroundings. So full risk is a big issue for us with injuries and with additional readmissions to the acute care hospital. So we found an AI-powered sensor that allow us to view the bed, and we can tell when a new admission comes in, the sensor's learning. It's trying to determine whether you're turning over in bed just because you're turning over in bed, or you're turning over because you're making motions that will result in you trying to get out of bed unassisted, maybe leading to a fall. And after 2 or 3 days, when this AI model understands the normal motions that the person goes through, we then get elimination of the false positives. We can alert the nurse very quickly when the patient is exhibiting motions that are indicative of them trying to get out of bed unsafely. We alert the nurse through a mobile device. The nurse can get to the room and assist the patient, maybe going to the restroom or being moved down the hall or whatever other changes that they needed to have. And we've substantially reduced the number of falls, especially the falls with injury, by using this AI-powered solution. So that's one area that we've embraced AI, and it's helped our caregiving and it's helped our patient satisfaction. A second area that we're investigating right now, we actually penned an exclusive pilot with an AI developer, is a companion application that will call a resident in their room on a daily basis and just have a chat with that resident. We preload information about their background, their family, their interests, and many of the residents in hospitals, long-term care facilities, and even in home care at their homes, they're relatively socially isolated. They don't have a lot of people to talk with. They're bored. They have nothing to do. This AI-powered conversational tool will make a phone call, learn from the previous phone call content, and have a conversation with them. It's very natural sounding. You wouldn't, after a few minutes, realize that you're talking to an AI-generated robot. And the amount of patient satisfaction and the amount of engagement that happens during these phone calls is amazing, to help people and get out of this isolation situation and be more interactive with all the rest of their items, having their needs for medication reduced, having their psychosocial needs met, and be able to live a better life by having these 10, 15, 20-minute interactions on a day-to-day basis via telephone with an AI-powered companion aid.
Those are two fascinating areas. I think, the observation piece, utilizing AI, and I know computer vision is being tied into that as well, to reduce RTAs, which is a critical piece in long-term care, not only for the patient, obviously, right? I mean, going back to the hospital isn't always the greatest solution. They're susceptible to acquiring infections by going back into the hospital. So it creates stress for the families, creates stress for the operation itself. So those are really critical, I think, areas to address in long-term care and skilled nursing facilities where you can make that difference. And sounds like you're on the cutting edge of doing that today. It's very interesting on the AI observation piece. I don't want to deviate too much, but David, very interested. I think maybe people in the audience would be too. From the discussion to implementation, obviously there's some learning that had to go into the system to be able to understand movement. How long was the period of that process to train the AI? And different patients there's a lot of variation there in patient size and other things that it has to understand within that room, in that bed that patient's in at your facility. Can you provide any insights in kind of that process of training and the length it took to get to the point where it is today, if you can?
Sure. And actually, it goes back a couple of steps before that, because we were trying to decide where to pilot this within our facility. We have 550 skilled nursing beds and wanted to find a unit that made sense to pilot this. So first we started on a long-term care unit, and that failed miserably because most of those residents are not there disoriented. They have most of their mobility faculties with them, and they have the right and the ability and wanting to be able to get up and around whenever they wanted to. So we tended to find many false positives because even though they were exiting the bed, they can, and they have the abilities to do that. The second area we piloted it was on memory care for those people with moderate and advanced dementia. And that again failed because it made no sense that many of the memory care residents, they suffer from what's called sundowner syndrome, where they get restless at night, they wander, they pace, they go up and down the hallways all night long, and again was setting up a lot of false positives alerts. So when we moved the sensors and the pilot to our short-term rehabilitation, which are the people that were recently discharged from the hospital after an acute illness or injury, and those were the people on the medications that were most at risk of falling, we found the sweet spot. We also developed an assessment to see which residents would make sense to use the sensor and which ones wouldn't. And then getting to the answer to your question, we see, I think 3 days is the sweet spot. For the first 3 days, the sensor and the AI models are learning about patterns for the particular resident, and it really didn't matter about the size or the shape or the age or the dimensions of the resident. After 3 days, we got the number of false positive alerts down to 1 or 2 a day per resident, as opposed to a dozen or so during the first 3 days of their stay, as the model fixes itself and adjusts itself to looking at patterns that really are indicative of them trying to get out of bed unassisted.
That's fascinating. And again, not to hit on it too many times on this webinar, but again, we've got pre-symptomatic representation here. We've got long-term care, skilled nursing, memory care, in care delivery. And now with Linnea, getting your perspective on delivery of care, your background as an RN, if you can give some of your thought of practical uses, maybe it's in place today, or even in your thoughts in areas where you see the ability to improve care delivery.
Yeah, Mark, happy to. I don't think there's a question or any secret about the shortage of healthcare providers that we plan to have. The U.S. Bureau of Labor predicts that there's going to be a need for almost 300,000 nurses by 2030, over 140,000 positions by 2040 as well. And so we're having to look at different care models. How can we still take care of the patients knowing that we're going to have limited staff to do it, or, needing to put in some work to get those staff numbers up to par. But we're also looking at virtual nursing right now. A lot of organizations have taken steps to look at different ways, different care models, different ways of taking care of your patients. So maybe that means you have a nurse who is in a central location who is able to assist with charting, who's able to answer the patient calls. And then knowing that you still have to have a physical nurse in the room with the patient to give assessments, to help with medication as well. But you do have that virtual person to kind of be an extension of yourself. And we're really seeing positive results from patients and families with having that virtual aspect. Maybe your family isn't able to hear some of your care, or maybe your discharge teachings. Now we can call you, kind of video you in and have that virtual nurse talk to them about the process. Also, home care is another area that we're seeing a lot of use for AI and technology innovations. Maybe you have a chronic condition, respiratory, or needing infusions. Instead of consistently having to go into a hospital or acute care setting, those things can be done at home now. The ability and what David mentioned of these wearable sensors, being able to feed some of the information back to your provider without you physically needing to be admitted to the hospital for an extended period of time. Simulations also is a key. We're seeing kind of the VR goggles come into the healthcare setting. COVID really hit us pretty hard with the ability of getting healthcare providers into care settings for clinical settings. And so we're looking to simulation and how we can kind of lean in to help our graduates really be prepared to take care of some of the individuals with chronic conditions. We're seeing sicker and sicker patients, which is contributing to the extended length of stay and our capacity being hitting the limits at capacity. So hoping that those areas can really make an improvement, and some of our more innovative organizations, whether they're rural or academic medical centers, are seeing the value in investing now in making improvements.
Can you expand a little bit? You brought up virtual nursing. A couple of things you brought up are very key and important, and I think affect everybody. Number one is you mentioned the shortage of clinical. It's clinical staff. It's also administrative staff. It's an aging of the providers. As we all know, with COVID, we lost a lot of clinical staff who retired early, and other reasons too, by the way. And if you look at demographics, it's a larger aging population that's going to demand more out of our healthcare system, with fewer and fewer providers to provide all the necessary. And that goes across long-term care and skilled nursing facilities where there's heavy staff turnover and retraining that has to be done. So there's a lot of areas here we could touch on where we can apply emerging technologies, AI. You mentioned AR and VR, and going back to virtual nursing, if you could maybe provide some details, if that's being implemented, if you're involved in it, if not, your views on it, how it's being implemented, benefits. Just like to explore that a little bit further. I think it's very interesting.
Absolutely. Great call. Recently I had the pleasure of moderating 5 large healthcare systems that were looking at different ways to give care to their patients, being innovative in a way of not just cutting costs, but also looking at their workforce. The workforce is burned out. You mentioned COVID as well, and being able to take on the extra shifts, and not to mention just our environment, our surrounding, anxiety, inflation playing a role into the mindset of individuals taking on these roles. And quite frankly, we're not seeing the same number of individuals sign up and go to school for some of these healthcare professions. And you mentioned administration and allied care, our physical therapists, occupational therapists, speech therapists as well. All of those areas really need focus, and we're starting to see the government put in some funding into those areas to support with the education. But going back to your original question of virtual care nursing, it looks different across the United States, to be honest. I can't say that one organization is doing it the same way across the board. Some organizations are focusing on admissions and discharges. Maybe they just have a virtual program that's going to focus on discharging patients, making sure that care is coordinated, making sure that your medications are sent to pharmacy. And then again, talking to your family or whoever is going to be responsible for taking care of you while you're at home. Not to mention, there was a survey that just came out that said by Kaufman Hall, 30% of the United States lives alone right now. And I think that's very important to think about as we're caring for those patients. They don't have someone at home to take care of them. Many people are by themselves. And so you have to think about transportation. How are you going to communicate with the individuals if they're sick? And then, long-term care, as our friend David here mentioned earlier. But some organizations with virtual care are looking at entire units, maybe. Maybe it's a medical surgical unit. And so you have one nurse who's responsible for taking care of 5 to 6 patients. Having that virtual care nurse, it's going to help take some of that load off a little bit. And maybe it's just with charting. But when you think about the amount of time that it takes for someone to stop everything that they're doing, focus on this one patient to chart, having someone to support them that they can communicate with, even bounce ideas off of, that takes a lot of weight off of your mental and physical capacity as well. So again, virtual nursing doesn't look the same across the board, but our physician partners are actually playing a role as well, getting their feedback and incorporating that into the workflow. Is I think going to be key, making sure that the entire care team is on board. Some of our healthcare organizations are going back to the way we did care, 10, 15, 20 years ago, called team nursing, making sure that you have the nurse, maybe you have an LPN, and that's a profession that, maybe our long-term, our skilled care facilities started to see, and now our acute care facilities are asking for the LPNs, our associate nurses, to come back into those acute care places as well, and partner with our allied and care techs. So looking at different care models, incorporating virtual and AI wherever we can. But there's an important technology aspect that needs to be thought about and considered with capital equipment cost as well. That's playing a role in how fast organizations are able to adopt virtual care nursing into their settings.
That's very interesting. I'm going to go to David here in a second, and I won't ignore Sarath either, but I want to get back to virtual reality only because it applies to long-term care to a degree. But I think it's important in our discussions on artificial intelligence as well, because depending on who you're talking to and looking at it, it's, is this ultimately going to replace, patient care with human beings? And I think the answer is no, because at this point in time, as far out as I can see, it's an augmentation, whether it be in administrative issues or even in delivery of care at the provider level, that it's an augmentation and a support piece, not intended, I don't believe, anytime near in my lifetime, to replace the experience and intuition, if you want to call it intuition. I call it experience of providers and the clinical providers and staff. And care is all about human beings delivering patient care. And I think that's critical. Where we can augment, because we're going to have gaps, right? We need to look at process automation. I know everybody's into that today too. We're working across all those areas through the whole continuum of care to improve the delivery and make it more efficient. With that, David, have you investigated, because there's a lot of long-term care facilities that have already implemented virtual reality, and immediately there's a reaction from a lot of people that aren't in the industry who feel, well, virtual reality, long-term care, they're not going to want to put on headsets for 30 minutes or whatever. It's just not but we're seeing it, and we're seeing it depending on the acuity. And you mentioned long-term care where people were mobile, skilled nursing where they're less mobile, maybe not so much, right? But in that long-term care piece, have you looked at virtual reality for your patients to give them at least a 30-minute experience with maybe something they're interested in, and having a family member perhaps join them in that virtual environment? Have you had thoughts on that or looked at that?
Yes, absolutely. We've embraced virtual reality for over 2 years now from many different perspectives, some just traditional and some very leading, cutting edge. So we started with a couple of headsets with the traditional, put the headset on and let's go through the Eiffel Tower or the space shuttle or the museum. We then are partnered with the vendor that we work with to input the address where you grew up, or input an address that you visited on vacation, so you can virtually walk through that. And that was the first foray into virtual reality here, and that was interesting, but we wanted to do much more. So we got into virtual reality for healthcare and for exercise. So we have a system called Rendeavor Fit, which is a kind of a pedal bicycle type device, and hand controllers. And using the virtual reality headset, the patient will kind of use the bike pedals to pedal their bike through the boardwalk and pop balloons along the way. So not only are they getting entertained, but they're also getting a little bit of exercise, and then the people around them can see on a big TV what they're experiencing. So it's kind of a group activity. The next area which really helped us a lot in our short-term rehabilitation and discharges, one of the challenges we had was when a patient came in maybe after a hip or a knee replacement, when they go back home, their home really isn't set up for success when they re-enter their residence. So what we do is we give a GoPro camera to the family member, and they take pictures of the home that the resident's going back into. We upload those into the headset, and before discharge, we can walk the resident virtually through their own house, point out trip hazards like area rugs, point out coffee tables that may be too close for the couch for the walker to be able to navigate. And we help them in making sure that when they get home, they will end up in a safer environment. The next area that we've done, since we had these GoPro cameras, let's help them experience activities that they couldn't ordinarily have. So if a grandson is playing a soccer game, or a granddaughter is in a dance recital, or a family member is getting married, we'll again loan those GoPro cameras, have them film the event, and upload those into the headsets and allow them to experience that activity after the fact, but be part of the family. And the last area that we've done is the vendor we're working with has embraced the metaverse. So we have the ability to provide headsets to family members in the community and the resident, and they can both join together in a kind of virtual reality space and talk with each other in real time using the headsets as a conduit to have a conversation in kind of just a metaverse type. So we've really embraced virtual reality. We were hesitant at the beginning. Seniors don't want to use it. They don't want to put anything on their head, but they've really embraced it. The last story we had about this was we had a memory care dementia resident that was very isolated, sat in the corner all day long and didn't do anything. We found out that he was previously very interested and was an opera singer. We put on a headset showing them an opera. After he took the headset, after not being verbal at all for 2 years in our facility, started singing opera for the first time in over 2 years. So there's many activities and abilities for virtual reality to bring people out of their shell and into a much more engaged environment.
That's a fascinating perspective. And David, can I follow up just really quickly and ask you, implementing it, novel at first, maybe, has it continued and maintained usage over time? I don't know how long I guess over 24 months now you've been
yeah, we started with 2 headsets about 2 years ago, and I guess the best way to explain it, we're up to 70 headsets across our campus. We have activities directors that run sessions all day long, every day, using these headsets, and just people are just waiting online, signing up for this because they really feel that this is a great way to experience outside the 4 walls of where they are.
I think there's a lot of underestimation. I think we found this in COVID, whether prior to COVID or at the onset of COVID, a lot of healthcare professionals were doubting that, seniors, I'll use the term, would adapt to being able to use tablets and other forms of communication. And we found that not to be true. And I found in long-term care that AR and VR initially, I found a lot of resistance that people said, well, the headsets are bulky. Nobody's going to have those on. They're not used to it. I think we're finding that, for your case, that it's successful and it makes a big difference in people's lives to do what you're doing. So it's a great piece of emerging tech that's actually working, and it doesn't have that adoption blip where, well, the first few months residents were using it, and then glasses or goggles are going to become, as we're seeing, much more lighter, much more similar to eventually what I'm wearing today. Make it much easier for anyone to have that experience and not feel the burden of where we're at today with the goggles. But that's fascinating, the kind of difference you're making in your patients' lives there too. With that, I want to
partnering with the right vendor and the right person, and the organization we work with, Rendeavor, is only focused in the senior care marketplace. So they trial, they study and look at every single headset model that's out there, pick the best ones for this. They have a person on their staff that gets very dizzy and disoriented when they use headsets. When they have new content and they have a new headset, he's the test bed. So if he doesn't make him dizzy, he knows that they know that it's a solution going forward. So they invest a lot of time, effort, and money in making sure the solution is the best way to provide for seniors.
I appreciate that. And to drive back into a little bit of AI adoption here and implementation, Sarath, can you give me some of your view, and then we'll go to the panel as well. With the risk associated with AI adoption, obviously, it's relatively new in healthcare in certain areas where we're utilizing it today. Obviously, governance is key. If you can give some idea, what strategies you ensure on data governance and compliance when implementing AI in your field.
Thank you, Mark. So I just wanted to say, after hearing what David said, I was thinking that I was working on the real world data, and like what David said is like on a totally other spectrum of utilizing AI in a real world environment, right? So that's so fascinating and heartwarming story to hear.
Yeah, there's a lot of questions about the ROI. I think that's some David's provided in an area where, again, if you're not in long-term care, if you're not in skilled nursing, you make some assumptions, right? And about the adoption of technology, and David's just proven that, and there's others, that that's not the case, and it's really improving the experience and the situation of being in long-term care for a lot, loneliness. There's other issues there that they impact your health. And we'll get into some of that in social determinants of health too. But if we can go back to data governance, and which is going to be key, implementing AI into your environment, if you can give us some of your background there and what you're doing today.
Yeah, definitely. So obviously AI in healthcare can be separated in three different areas, right? Like one on the administrative side, next on the diagnosis clinical care side, and third on the research side, right? On the research side is where I'm mainly focused on, but I know Columbia is trying to implement some on the administrative side and the diagnosis side as well, in terms of like creating a daily summary, but it is not implemented yet. It's about getting the robustness and making sure there is no errors in terms or bias in terms of the data that comes out of it. And it's also like going to the research side, like one area that we are working on, as I said, are the imaging data analysis, right? So we work on rare diseases, rare kidney diseases, and one of those diseases is autosomal dominant polycystic kidney disorder. These are like cysts that are getting formed in the kidney, and patients can go unnoticed for a long time until they are later in life, right? So the way to identify that is if we get the kidney like MRI done, and then identifying the volume of the kidney, and that's how we get to know that they actually have progressed and to an end-stage kidney disease where they would need to either get a transplant or actually have more like dialysis, go on a dialysis path. Right, that's where AI is actually helping us here in identifying the volume of the kidney by segmenting these MRI images. Until now, the radiologists have been looking at these images and trying to get the volume calculated by just an approximate volume from the ultrasound data, actually, to look at the length and the size of the kidney, and then getting an approximate volume is how they actually use this to predict. But with the advancement of AI, it can actually segment these images and then try to give you these actual total kidney volume in less than 30 minutes. So what used to take hours to identify, now it takes less than 30 minutes to give these results. So, but the problem comes in how to get this into the clinical care, right? So this kind of algorithm and models exist in the research world, but how to get it to the actual clinical care aspect is like getting the robustness. It is good that it is working for a particular technology. Okay, this particular institute uses this particular technology to get the MRI scans, but then how do we make sure that it would actually work on every different instrument that is available there, and it is robust across every other population data that is there? And that's the key aspect of it. And so it's a lot harder in getting these research-based models into the clinical care, which is what I wanted to get across. But I will love to hear from Liana and David on how they would actually implement it. It's actually fascinating to hear them.
Can I ask you, just in your area, which is a little different than the other panel members, and I think it's very interesting too, though, is, and it affects everyone on the panel, but I mean, eliminating bias. Bias is still a very real issue in these data sets. Maybe not in DICOM images or whatever are more truthful, if that's a word I can use to describe it. But how are you handling bias in the data that you're utilizing today? Because you're very specifically, relying on the data sets that you have for things that are impacting down the line. There's great impact in what you do.
Yeah. So population stratification is something that we try to do, and I know I'm coming from a genomics background, right? There is a lot of bias in terms of the data that is available, right? So all the research, all the data that is available until now covers 90% of European ancestry population, right? There is very less representation of people from other ancestries that are into the data mix. So any model that we come up with would have an impact that it won't be applicable to other like ancestries. So that is one of the major issues. So, and that is also the reason that it takes so we are like, the work needs to be not on building these models now. The work needs to be done on creating more data sets that it is actually more representative of the entire population, not just focused on one subpopulation, right? So more distributed population is what like the genomic field is working towards, but obviously it's not there yet. And bias can happen, whether it is gender bias or in terms of ancestral bias. There is a lot more involved in there. So,
and also another question that kind of leads into that, just to give me to size it. What's the size of the data that you're utilizing? I mean, how vast is the data sources that you utilize in your work?
okay. Sorry, can you repeat that question again?
It was a question on the amount of data, the data size of the different sources. I mean, how vast is the data that you have to access and utilize in your work?
Okay, so yeah, like the whole genome sequencing of one patient could be from 100 gigs. That's just for one sample.
Okay.
Right, 100 gigs of data for one patient. And if we have to work on a large-scale research project, right, we need hundreds of thousands of data in order to actually make any meaningful impact. So it goes on for petabytes of data that we have to actually work with in order to actually get some meaningful results in there. So, and like obviously it depends on what we are looking for. If we are looking for only the coding regions of the genome, and which is called the exome, then it's a little smaller. It could be from a few gigs. The file sizes could be from few gigs to like 7-8 gigs, depending on how much detail that you have, how much quality, like how much depth the sequencing depth is there for each sample. And yeah, that's the data size that we work with. So which is one of the issues where it is harder to actually put that in, getting it integrated into the EHR system, right? It's not so easy to just bring in a huge dump of data and just dump it into the EHR system. It's not set up in a way to handle that. So,
and that leads right into my question, which I'm going to move to everybody else too. But while we're talking, and you brought it up, what are the best practices to integrating AI and digital into the digital health platforms in existing EHRs, for example?
I would defer to Liana and David on that, and then I will come back to that on an answer, because I don't want to be the person saying that it's not there yet.
I understand. David or Lydia, do you want to take that on?
Yeah,
it's not there yet. It's the EMR vendors, especially in the post-acute long-term care, where the solutions are 10% complex as the hospital systems. They talk a good game. They say AI is coming to help with the care delivery, but we have not seen any movement at all on that side. Everything that we collect and use on the AI side is very much disjointed and separated from everything else in our record.
I was just going to kind of add the same. I would say, maybe 5 years ago, everyone kind of did their own thing. Things were not integrating very well. And so you can have multiple different systems within one healthcare organization. And to be honest, it was a mess. I think some vendors, some suppliers have really honed in on some of the key electronic health records, Cerner, Epic, and they're starting to feed into those quite a bit more, given the feedback that they've got to be integrated. They must be able to talk to each other. It doesn't make sense otherwise.
I think care continuity is key to improving patient outcomes. So understanding the interoperability, I think we've made some inroads from where we were, 5 years ago. I think it's going to get better. I understand that, that's not the reality for you today. But I think we're going to get there. There's a question that came in, and and it ties into this. It's not specifically AI, but AI does play into it. And the question was, with the rise of digital health platforms, how can healthcare industry safeguard sensitive data? Of course, PHI is top of mind for everybody in privacy and security because we handle so much of it. So how can you safeguard that sensitive data, ensuring that the patients will have a seamless, instant access to their health information? And that gets into interoperability and what's available to patients and information, and begs the question that's even beyond that question is, I was in a seminar yesterday where a neurologist was bringing up having all this access to all these reports and images and on and on and on. And I think that's great for some people, but some people it's what with all data. Go back, Linnea, David, if you want to handle that on securing PHI. Either one of you,
Yeah.
jump in.
Sure. Securing a PHI it's an ongoing process. I think right now we are working to educate staff on, whether it's emails and phishing scams. Recently, I've had 2 organizations within our membership who were targeted for a cyber attack, and how are healthcare organizations going to navigate that avenue? Are they going to pay the ransom, or they're putting together significant IT teams just for cybersecurity? And I think it's absolutely necessary that we invest in that area right now. On the delivery side of things, it's communicate and awareness. As a healthcare professional, we're not always at the tip of information when it comes to cybersecurity awareness. So getting your teams aware of things to look at and look for, simple things. And it's an education piece for us right now, to be honest, just for awareness. Happy to hear other people's thoughts on that, though.
David?
I think that there's a lot of change afoot. I mean, we have the national TEFCA initiatives. We have the 1115 waiver in New York, information blocking choices. Many, if not all, of the EMR and EHR vendors are in the cloud. We've had recent Change Healthcare breaches. We've had the CrowdStrike issue, and with all of that, the residents, the patients, wherever you are, you have the right to your information. So the systems have to be open enough, but at the same time, we have to figure out how to protect the information to make it accessible, minimum necessary in order to comply with the HIPAA regulations. So it's a balancing act, and no one's done it perfectly, but we're all trying to end up in the right result of getting the right information to the right place at the right time without the wrong people getting access to it.
And just to add on to what David said, if you don't mind, I'm starting to see a lot of more of kind of homegrown AI governance committees within healthcare organizations as well. Individuals coming together and determining how some of this information will be shared, and also deciding which vendors, which suppliers they will partner with. I think initially everyone was very excited, and we're going to try this and we're going to try that, and let's hop into this. The vendor says promises that we're going to see this result, and now there's a committee. We're coming to a central location and deciding, being very specific on the partnerships that you have as well.
You bring up a great point there, and I see that being formed with IDNs and other hospital systems to build that governance into it, and also bring in the clinical staff, because obviously workflow implications, their input is key from the very front end of adoption. So I think, again, the patient's at the forefront of everything. The clinical staff delivering the healthcare is critical and key to be part of that, and understanding of that. There's certainly more risk, and it's not a cybersecurity webinar, so we're not going to get into the advances in phishing now with AI, being able to learn a lot more about your persona to be able to infiltrate your organization and duplicate and look very similar to legitimate emails that make it more and more difficult for teams, even though training is happening on some places quarterly, annually, with their own internal phishing testing that they'll do against their own employees. But it's an ever-evolving landscape. So AI is bringing some great benefits. Also, on the other side, some of the bad actors are have been using it. They'll use it again for deep fakes. That'll become a big concern. Won't go on that tangent, but if there's any other issues, David, that you want to add to the security concerns of adopting AI, maybe in your organization.
We've since we are not on the Office 365 suite yet, we've kind of give directive to the organization: learn, experiment, play with the large language models, with the chatbots and everything like that. But remember, this is all going into a public data set, and don't put any PHI, don't put any personal information. And that's trying to keep that firewall of, yes, you want to use it, yes, you want to experiment with it, but keep it sterile so we don't have patient information as you use it. It's a challenging communication effort, but we do the best to make that work.
Sarath, any thoughts on?
I just wanted to say that it's a lot of education that needs to happen, right? Like coming from the genomics background, it's a lot harder for us to actually educate the people involved about genetics and genomics, where we know there are like exact results and explainable results that we have. But it's not the same case with the AI and other fields, right? So it's about educating them of what they are using and what the data that is coming out of it. And only then, like, it's about giving the ownership to each one that is using the tool, right? If we bring any tool, it's the users that are going to actually have to take up the responsibility in being more secure, in keeping the data secure and what they put in, right? We can come up with guidelines saying that you should not be putting PHI in there, but it's about educating the users to letting them know that what could happen if they actually throw in the PHI information in there. And from the genomic side, it's a lot more harder, because with genetic data, re-identification is easily possible. So that's why there is like very less of outcomes that have come in terms of foundational models in genomics, right? Because the chance of re-identification and the amount of data that is required is very much high. So yeah, there is a lot more risk of data privacy involved in there.
Thanks for that. I want to dive into, with our time that we have remaining too, and I'm going to leave it with you because I'm going to get into population health, which I'll bring in David and Linnea have some great perspective there, and as you will as well. But how can genomics-driven personalized medicine revolutionize patient care? I mean, what do you see there?
It's actually already has revolutionized in terms of care, right? So genomics has actually made a huge impact on 3 different areas. One is cancer genomics, where it has helped in identifying earlier who could get a cancer, and also what is the prognosis, what is the reoccurrences of those cancer, and it has also helped in terms of specialized treatments. But there is also 2 other areas, which is rare disease genomics, and also the third one, which is like the common diseases like type 2 diabetes or hypertension. It has also helped in those areas as well. So yeah, so it's already there in terms of genomics, but then the interesting aspect comes when we add the AI into it, right? Until now, we have seen solutions or diagnosis that is coming from one modality of data, like be it only the genetic data. Now, what would happen if we combine the multimodality data? That is, if we classify a patient having a certain disease and this is their progression rate in terms of imaging, and then we do the same in terms of genetic data, and then if we do that also in terms of their clinical trial, like in terms of what kind of symptoms they have, right? How often they come back to the clinic. And when we combine all these 3 things together, then it could actually revolutionize in how much personalized care we give back to the patient, right? So that's where I see the field moving towards, and there is a lot more scope. Once we venture into this, there is a lot more scope in terms of adding like the metabolic data and also the exposomic data, like the environmental data, right? Which environment and what lifestyles they live in. When we combine all these things, that's when it gets much more personalized. But we are getting there So that's what I even envision the field moving towards.
And something that's very interesting that you brought up earlier, it kind of ties into that too, is, you know, the available phenotypes for certain populations within the globe that are not available. How is that being addressed for those models, to have a diverse genomic database? I mean, obviously, African population, Asian population, non-European population, to have those kind of databases that we talked about. How do you see that being integrated, and that information getting to the point where we can provide that kind of risk assessment, predictive assessments for those parts of our key populations?
So it's, thanks for asking that question. So actually, that's where NIH came into play, that they set up all of us as a program to actually sequence people from minority population and of different minority ancestries, right? Instead of not focusing only on the European population, they tried to focus more to get sequence and also collect all their EHR data. So this is an ambitious project of sequencing 1 million US population with different ancestries, right? Sequencing them and getting their whole genome sequenced, and also keeping track of all their wearable data and any kind of survey data that they are ready to give, and also the EHR data. So this kind of a large data set, that too coming from accessible data from the NIH, is actually adds a lot of value in there. And then there are other H3 Africa is another consortium of African countries coming together to sequence and keep the data there, and trying to get more data that is focused on there. So for example, one of the areas that in precision medicine is pharmacogenomics, where we try to tailor what kind of drug a person can actually take in, right? So for one person can take in one drug, but for another person, you have to up the dosage for them to actually have an impact of the drug. So this is explainable in terms of what kind of genotype that they have, but then genotype in the sense what kind of mutations that they have in their DNA could actually decide what kind of metabolizer they are for the drug. And now all these until now, whatever we have identified, okay, this drug, this genotype is the association, that has been made from the European population. So when we talk about personalized medicine, it's not directly applicable to all ancestries, because our underlying data is actually not represented well. So hopefully approaches like all of us and the H3 Africa, and there are a lot more smaller consortiums from the Asian countries as well. So bringing in all these data together would actually address these kind of issues.
And I'll make this quick. I don't want to monopolize it on genomics either, but what's the role for synthetic data? Can it be applicable, not applicable? In that?
It cannot be, because it's very diverse, right? In terms of genomic data, it's very diverse. It's harder to predict the diverseness that comes in. And like, if we had solved that, then we would have solved the mystery behind the genome, right? So if we know what difference between your genome and my genome has, to create it as a synthetic data, it's much harder in terms of synthetic data to recreate that. So
thanks for answering
and also
that.
it evolves through every generation, right? So the DNA keeps evolving through every generation. So it's constantly mutating, just like how we have seen for the COVID variant, right? There were a lot more variants coming in every year. So same way, there is changes happening.
Thanks for that. Linnea, can I ask you about SDOH, social determinants of health, and how you see that decreasing the length of stay and improving capacity? And I'll ask that same with David, but if you want to start, Linnea, on population health, social determinants of health being implemented.
Yeah. So we know social determinants of health, housing instability, food insecurities, transportation barriers, having limited access to education will significantly influence an individual's health outcomes, right? So by being able to screen for these factors, healthcare providers, hospitals, IDNs can now provide or gain a more comprehensive understanding of a patient's lives beyond their medical conditions. And I think this holistic approach really allows for a tailored interventions that address the root cause of health disparities. It gives insights to the health patients' needs, even your employees, right? Like your employees are going to be living in these areas close to their workplace as well.
Right.
So
Right.
it's helping with benefits, childcare, transportation, workforce retention, but looking at your social determinants of health in response of capacity and length of stay. I think you have a more thorough understanding of who you're treating and how to treat them better and how to, quite frankly, keep them out of the healthcare system if possible, provide more primary care. It's helping our healthcare organizations also tailor where they should be investing in. We're seeing a little bit less of the large medical centers, right? We're seeing smaller healthcare facilities pop up that are tailored towards maybe chronic care or orthopedics, maybe. And so it's telling us where we need to have dialysis centers also, and where to invest in the zip codes. I know Vizient has our Vizient Vulnerability Index, which looks at zip codes for individuals as well, and says, hey, 30% or 70% of your individuals have congested heart failure. Maybe we need to bring in some education here. Maybe this zip code it's in a food desert and we need to invest in proper nutrition and access to food locations in this space. So really honing in on that holistic aspect of things.
I think I agree. I think everybody realizes how key it is that healthcare is, you say holistic. I mean, there's so many things impacting your healthcare, and you've touched on, I think, most of the critical ones that could have a detriment on either receiving care, the right care at the right time, or your predisposition to certain illnesses. David, in the long-term care area, can you enlighten us a little bit on if you're using it, how you're using it, the importance of using it, on understanding that holistic?
Yeah, we're using it kind of in a limited basis, but we're informing our discharge planning process in our home care agency. So when we have discharges from our skilled nursing facility with patients going back to their home, we look at zip codes, we look at the areas where they're going into, and we're coordinating with our home care agency to really fill in the gap for services that may or may not be available in those areas of where they're being discharged, and make referrals to food banks, make referrals to community physicians or therapists or other areas that would help supplement them and give them a better chance of a successful discharge and recovery after they leave our facility.
Interesting. And we've got a little time left here. I wanted to ask everybody here with healthcare leadership, how can healthcare leaders effectively address the resistance to change among staff when implementing these new technologies? We've talked about a lot of new technologies, long-term care, in traditional care delivery models. And we can talk about that even in Sarat's position too, dealing with leadership and staff. So how do you address the resistance to change? Anybody on the panel want to take that up? I think everybody should be able to comment on that too and give your perspective.
I think it starts with the leadership empowering the team, the caregiving team, the operational team to think of outside the box. Don't think about the four walls that you've grown up in and that you've been traditionally with. We encourage our clinical team, bring to us ideas that will help you get your job done more efficiently and effectively. We look at ideas from residents that live in our facility to look at systems and technologies that will help them in living a better life. And we really do it down to the grassroots effort. We also realized early on, project management is key to success of implementation of any technology systems. So we invested in a project management team that takes the projects through the entire life cycle, engages all the constituents, making sure that the residents, the staff, the technology vendors are engaged from the beginning, so we're not just throwing technology out and figuring out if things stick. And that's really helped us be successful and have allowed senior management to allow us to invest in additional technologies because we've been successful with the previous rounds that we've done.
Leadership is key to setting the tone for the whole organization and having everybody understanding how, I guess, the implementation of those technologies don't interfere with workflows unnecessarily and create workarounds. I think that's key. Linnea, same question. I know you've got experience going back through your different roles as well, where you've had those challenges with staff and implementing new technology.
I think resistance is a normal part of just the change, right? You have the norming, the storming piece, and I like David mentioned, get them involved early, bring everyone to the table, have that transparency so that they know exactly what's happening. Mark, I think you mentioned earlier that technology is not going to take in people's jobs right now, right? I think emphasizing that, or maybe even reinforcing that idea that this is not here to take your job, but really to support you and to help alleviate some of the burdens of the work. I think when you're able to kind of switch the narrative and let individuals understand that this is a supportive measure used to enhance your abilities, your perspective changes a little bit. So communicate, communicate, communicate.
I think that's perfect. Communications is key across the board. Sarath, what do you view there on implementing new technologies and the challenges with adoption from staff and leadership?
Change is always hard. It is not easy to push through, right? It's about having the vision. What is the vision? Like connecting them, like Liana said, it's about communicating the vision that we have. And then making sure that the people that we are asking to change have the right set of skill set in terms of technology to get there. If not, giving them the opportunity to level up the skills to get there, right? You cannot just throw in a technology and then ask them to use it. It's about creating an environment where they can actually learn. And then what are the incentives for them to use it? Right? Is there any incentive for them? Like, does it reduce their workload, or is it going to better their workflows that they are currently using? And then also creating the right set of resources for them, right? Do they have enough resources to actually implement the change that we are trying to do? And then creating an action plan. Like, okay, this is the step-by-step approach that we are going to do in order to make this change possible, right? So combining all these 5 components of vision, skill, incentive, resources, and action plan is actually the key to getting a successful change happen. So
I think if we can bring anybody into the new technology and have them be there early on to understand the benefits and how it may reduce or make them more efficient in their position and get the buy-in, obviously that's going to be key. We've got some great questions as we wrap up. I want to make sure that we get to them as well. They're critical. I think everybody can answer them because they impact everybody that's on this panel too. So it's regulatory challenges, which everyone in each aspect of every industry that's represented here is burdensome at times, right? Necessary at times. I'd ask the panel, what are the most critical regulatory challenges facing the adoption of innovative healthcare technologies, and how can organizations navigate those regulatory challenges? Whoever wants to start first, everybody's affected here. Lydia, do you want to take a stab at that?
Sure. Absolutely. The regulatory challenges, great question, by the way.
Absolutely.
Within the healthcare setting, I think the regulatory standards are catching up to AI. I don't think it's incorporated just yet. We're starting to see little bit pieces, more and more recommendations. How are you incorporating AI? I'm thinking about a magnet designations, for instance. They finally changed their standards after 16 years, and it's thrown a loophole for some of our healthcare organizations. And one of the pieces is, how are you incorporating AI into your ambulatory settings? A completely different piece that individuals haven't been focusing on. I think we focused on the acute care and in the hospitals. And now, we talked about the long-term care. We've talked about care at home in these different settings. And so regulatory challenges it's new for us, to be honest. I think individuals are going to have to sit down and strategize exactly how we're going to jump hurdles, whether it's security or whether it's being able to meet CMS standards as well. And I think we're going to see AI being tailored towards meeting those regulatory challenges that we see along the way as well. But right now, I think they're still being brought to the table, and quite frankly, we're working through them right now.
Well, certainly AI has exploded, although it's been around for decades now. But I mean, certainly in the environments that we're implementing them, that regulating them, as we've seen in states. I'm in a state that's developing regulations. Individual states developing regulations can, it's an opinion, can be problematic. We'll have the European laws as well for AI, but it's exploding and it's changing so rapidly that it's almost like chasing a mirage. As I tell people that, we need regulation, we need governance, and governance starts locally. Locally, when I say locally, I'm not talking politically. I think within the organizations that you work in. David, you're certainly under an industry that's heavily regulated, facing staffing regulation changes and mandatory staffing regulation. How are you handling the adoption of innovative healthcare technologies and with all the regulatory challenges you face?
I guess the biggest challenge we have is when the state surveyors come in or the federal surveyors come in, is trying to help them understand the new record and understand the treatment decisions that were made on not necessarily having all the evidence in black and white in the pieces of paper. That the sensor told us to go to this resident's room because they were fall risk. Where is that documented, and how is that determined? What is the data elements or inputs that we use? So it's more educating the surveyors and having them understand that the system is learning and that not everything is going to be concrete, check the box or click off a button for compliance, and having them understand that process. That's been the biggest challenge that we've seen.
Trusting. And Sarath, so you're certainly under heavy regulations as well. How do you navigate that? Yeah.
So I would agree with what you said. Right. It's about having local governance. Right. Every institution should have their own governing body, which actually looks after it, because they know their environment better, and also they know what is good for their patients. Right. So like getting a better understanding and a stronger local regulating body would actually have a great impact in navigating through these challenges.
I appreciate that. As we get close to wrapping up, David, I've got a specific question for you, and that's, how do you envision the role of technology in enhancing the quality of life for residents in senior living environments? I think we've talked a little about AR, VR, and AI for preventing one of the biggest risks is fall. If there's anything else in there you want to touch on.
Really just discuss one of the other technologies that we've helped in our long-term care facility is something called the REDS vest. This is a device that was born out of Israeli military technology, and it can see through walls, and it can determine down to the milliliter the amount of fluid in someone's lungs. And when we put someone that is at risk for CHF, for fluid buildup and hospitalization, we put them on a protocol to test this on a day-to-day basis, we have resulted in 0 hospitalizations for CHF over the last year that we've used this. So those types of technologies, engaging the residents and engaging the staff in using these technologies that are not typically found in long-term care facilities, have enhanced the lives, have reduced unnecessary hospitalizations to keep them in place, and has really created financial efficiencies for the organization as well, so that we can continue to invest these type of technologies going forward.
it's been very interesting. And I think a lot of people don't realize when they think of long-term care, it's under margin pressure, it's scrutinized, understaffed, staff turnover, that, there's so much innovation that you're doing, David. It's very interesting to understand that. And I think the audience would appreciate that too, because we have to look at, again, this panel has been really interesting, and we're going to close out. I'm going to turn it back over, but thinking through the panel, again, I got to say that, we're at the forefront and looking how we can prevent disease. And then we're at the care delivery side to the point of being at the long-term skilled nursing facility care delivery side. And there's innovation across all those fields to improve human lives, which is why we're all here today. I want to thank each panel member for their viewpoint today and their perspectives. Archera, I'm going to turn it over to you, and I appreciate the audience for joining us today. I wish we had more time, but we tried to cover as much as we could. I think we answered the questions that we did get. If there's additional questions, they can submit those, and we'll make sure those get answered.
Thank you, Mark, for helping moderate this.
Well, thank you.
Sure, Mark. Let me just wrap up the session for you. As Mark kept mentioning, this was a very interesting and intriguing session. Thank you, Mark. Thank you, speakers, Linnea, Sharad, and David, for your outstanding contributions and willingness to get together and offer such insightful opinions. It offered a forum for knowledge development. We extend our gratitude to our community partners and attendees. In case if you feel you missed any part of the conversation or just wish to look back at the session, we have got you covered. Today's event was live on our company's YouTube page, so you can see the recording anytime. And if you are looking out for recent technological updates and advancements, log on to our website at www.aicorespot.io and visit our social media channels. We will share cutting-edge topic discussions with a focus on banking, finance, insurance, telecom, retail, healthcare, and more. So more details, announcements of the next events, which will help you register and attend them. We'd love your support. Don't forget to like and share our content. Remember, we want to hear from you, know what you like to hear from us, and stay connected. It was great sharing this session with you, and we hope you liked it as much as we did. Until next time, take care and great day ahead. Thank you.
Thank you.
Thank you.